think that the topic of this conference is highly relevant around the globe. How can we improve capacity in the healthcare sector by using new technology? How can we add on with new knowledge, new projects, new initiatives towards all levels of from policy to clinical practice?
Diving right into it with remote patient monitoring, just going to do just a brief telemedicine history. We already kind of got some good content on that. But the main point I'm bringing up here is that, this concept's been around for a long time. And it might be a little hard to see here in this image, but, it's basically talking about the radio doctor. And this is back in 1924. And so, this has caught the imagination of people for a long time. And when I kind of shared some of these slides at our last conference down in Australia, I was informed that they had actually been using, systems with Morse code even kind of further back then. So it is not new, but we've seen it kind of move through several different stages as this concept builds and we get more evolved with it.
So maybe it's not just technologies, but also the way that we make up programs around the technologies. That's where we can do it better. And not think that it's just the technology itself that makes it, but maybe teaching patients education.
Well, the problem that we saw was that any kinds of digital inequity were also going to reinforce health inequity. So that seems like a very obvious statement, right? Because health is so dependent now on connectivity and on digital solutions, that if you've got a population that doesn't have access to digital, you've got a population that doesn't have access to health. And often those are already the populations that suffer from the burden of health disparities. And often we're thinking about, well, are we high tech or are we high touch? And I think of this as a continuum where you could be at any position on that continuum at the same time. So I think instead of the right tech and the right touch, depending on the need. And again, thinking about the vast majority of technologies that could be brought to bear in the digital health ecosystem.
And that COVID has taught us that we have to work differently in future if we are going to provide care with this reduced capacity that we've got in our workforce. We've got to make better use of our current workforce. And we looked at what's the environmental impact of that? Because if we can improve our environment, that is also going to increase workforce capacity. It's going to make people more able to keep well, to keep fit, to keep in the healthcare organisation and to provide care. Now let's move to patients. What do patients want? There's been a ton of work on this, but basically patients want ease and convenience, they want trust, and they want choice, and they want to experience care as a journey, not just as an individual single episode. And who's done this best? The retail industry, no question about it. The retail industry has dramatically changed and has taken a customer-focused, rather than a patient-focused, but a customer-focused approach. There's been this big focus on consumers, which, as Birthe was saying, we should be arguing for absolutely within healthcare, but very importantly, a focus on asynchronous interactions. A huge process on asynchronous interactions, which we have not yet got in healthcare. We talk about store and forward, and we do a bit of it here and there, but it's not an absolutely upfront approach to digital or general healthcare in most disciplines or in most places. We've got to start pushing health technology much, much more strongly around our health systems. We've got to start changing traditional ways, becoming more consumer-focused.
What can I do as a leader in my healthcare system? How can I take concrete action on thinking about this and moving across these levels of influence? And so I'll start with another framework, just as an organizing principle, of how to take a health equity or an anti-racist approach to whatever type of intervention or program or policy we're in charge of it in our daily work. Excuse me. And so this is just one exemplar health equity framework from the Institute for Healthcare Improvement that came out a while ago. And we use this as a way to come up with concrete strategies for telemedicine that address these health equity pillars. And I think it's this approach and these principles can apply whether or not you're a leader in a healthcare system or you lead a health equity, or a digital health research team moving forward. So those are the 5 pillars. So to break them up independently, the first, and I think the most fundamental, is in any work, as any leader in our institutions, we have to actually identify health equity as a strategic priority of what we're going to work on. And that means a leader who is committed to the topic area and is committed to building technology with health equity in mind. It also means resources and time and effort to think through what that will look like on your team. And then the other piece that comes with leadership and strategic priorities, focusing on health equity, you need data, right? You need to look at the data within your institution or within your group and understand where the disparities exist, where the interventions need to be targeted. And then lastly, bringing it back to that multi-level domain, you need to be willing to think within your institution, but also external to your institution for policies that will actually impact equity within your own institution. So broadband for telemedicine is a great one. I don't think many people in healthcare institutions were advocating for broadband 5 years ago, very, very often. But today, if you think about healthcare leaders, at least in the United States, but probably nationwide, they think of it as a health priority for them on an everyday basis.
In their home environment, one of the most interesting things we found is that the occupational therapists who work with children on learning how to dress themselves, for example, or brush their teeth, were able to do that really well in the child's own home, because they were able to say, like, okay, now like we're gonna go to your closet and like this is exactly like where your clothes are, and really like practice, and this is how high your counter is. And so really to practice those things like within the home was very effective. So they're continuing to do that for those types of visits.
The promise of digital health tech is huge. I think it's accessible, it can be cheaper, it can be much more efficient, it can reach everyone. I work in Uganda part-time, so we have huge global health implications there. 90% of Ugandans never see a doctor in their whole life, so many of them have cell phones now, some of them have smartphones. Telehealth could be really important for these global health populations. But in order to realize the promise of technical innovation, it's not sufficient to solve the technical hurdles, but we also need to work together on patient-centered regulation to level the playing field and ensure technology reaches the people it can benefit.
So we started thinking about what is care at home? How can we fundamentally redesign care and think about, now we have technologies, we already established before 1990, we did not have technology. It was not scalable to go to the patient's home, but it was scalable to ask patient to come to us. But now there's a chance of really changing the segment and making patient-centric care back again, back to the future. And what we realized that across the health systems, they are talking about all 5 venues of care. It's a care continuum they are talking about, right? It's ambulatory care. Think about the virtual care done at home. Telestroke care can be done at the hub centers. Think about remote patient monitoring done at home. Nancy, you talked about some of the ortho examples, right? So there's so much we can do, and I'll show some of the data. 25% of the care can be actually redesigned completely from the venues they are being right now delivered.
We're not going to solve digital equity on our own. We're not going to solve it on the policy angle. We're not going to solve it in the institutional level. But many of us have expertise in these domains. So these are just examples. Public libraries, nonprofits, community-based organizations, places that have access to programs for broadband connectivity, devices, and skill building. Again, as we, as a research team or as an organization, can really think more thoughtfully about who can be a part of the team and what kinds of training and support we can provide. And this is, I think, how the health institution can actually be addressing the health equity and the anti-racism goals that they're working through. And I think that's why I try to keep the talk broad, because I think there are low-hanging fruit here that we all can do. I would say some of the most practical strategies I have seen have really been in the tailoring of telehealth or digital interventions based on patients' needs. And I've seen it both in clinical and I've seen it in research studies where really expanding the sample and the population of who's interacting with whatever technology we do. So I showed you the Alameda Health example of just asking simple questions about devices and data plans and skills and comfort in using it. And then the interventions that wrap around that can be pretty pragmatic, right? If somebody doesn't have a device, your next step is really to connect them with a device program. If somebody has a skill building process, that's something you can probably work on one-on-one or in groups. And I think those are the practical strategies. They might seem overwhelming if you're trying to just get the digital product in the hand of somebody and have them use it. But I think a lot of where I think we have been in the pandemic and before the pandemic has been missing a huge part of the population and thinking about I'm talking about 5 questions that we can ask to really get at the heart of the issues and then deliver tailored information. How can we offer digital first to everybody? For people who can't use the digital platform, how can we then re-randomize them to more intensive support to be able to use the product? We need to be thinking much more creatively about what we're doing. And I would say so it blends into the implementation space, not just in the platforms themselves.
It really does come down to the trust. And I think one of the things that we did for the program is we wanted to put the clinic front and center. So it wasn't like, Activate, which happens to be at Livingston. The patients learned the health coach. They learned, Juan, that was what Activate was for them. It was the actual clinic and that staff.